let's go on to Dr. Kamran Rostami. He went to a Romanian university because I Googled that because I didn't know where Bucharest was. And he then moved on to the Netherlands where he did a lot of his study. And I had to Google also what he'll explain it to you, seronegative. What he was able to do was figure out where people didn't easily get diagnosed as celiac. So he was able to say where they didn't, when you test their blood and it doesn't really show the high, is it TGT? I'm going way out of my range, but Cameron's nodding, so that's great. So, you know, talking about people that do great work, here he is, he's found a whole heap of people that wouldn't have otherwise been diagnosed. So I think that's pretty awesome. He's now moved to Palmerston North, and it's really great that we've got him up here. He's done huge amounts of study in the area of celiac disease, and he's going to talk about the management of non-responsive celiac disease. So those of you that are in the room that have got non-responsive celiac disease, our thoughts go out to you, because those of us that can actually cope with a gluten-free diet, we probably can't imagine what it would be like not to. And so to hear from Cameron would be really important. I'll ask him to come up and start his presentation.
Well, thank you, Sam, for the kind introduction, and would like to thank the organizer, Wendy, Richard, and everyone actually who was Dana, who organized this important conference. And I have the privilege here to talk about celiac disease, especially non-responsive. Also want to thank Tanya, who taught us to breathe, which is very important to relax. How do I go to the next one? Yes. So I'm going to talk a little bit about the history, a bit about prevalence of celiac disease, the clinical presentation, and a bit about histology, how it looked like, the small bowels, and then going to touch base on non-responsive celiac disease. This is celiac disease in 1938. On that time, gluten-free diet was not discovered yet. Celiac disease is obviously an immune-related enteropathy caused by gluten, which is a protein in wheat, rye, and barley. And it was, first description was Samuel G., a physician in London, about 140 years ago, actually described celiac disease. But only in 1950 was a Dutch pediatrician, William Dicke, who discovered the treatment of celiac disease with gluten-free diet. Oh, sorry. I'm not sure why I'm not getting to that. Okay, the difficulty of celiac disease is atypical presentation. Those classical celiac disease is only the tip of the iceberg. And the majority of patients actually present with a typical form of disease, which is atypical serology, histology under the form of silent, latent, and potential celiac disease. The prevalence of celiac disease was considered a very rare disease in 1950. Just only 1 in 10,000 people had classical form of disease, but that has increased by developing the sensitive serological tests like endomysial antibody and TTG. And by using this test, the prevalence has increased to 1 in 100. But when you put together every gluten-related disorder, we are looking at about 15% of general population has got a kind of gluten sensitivity, which is considered a significant health concern. Anemia is a major extraintestinal manifestation of celiac disease. So it's over 54% of people present with iron deficiency anemia, but also megaloblastic anemia like vitamin B12 deficiency, folate deficiency is also common, especially in elderly. No matter how affected is your small bowel, whether it is mild or severe, osteoporosis is one of the complications of celiac disease. And unfortunately, it's very common in people, older people over 50. Thus, we recommend that people in that age group certainly have a bone scan, but also considering a bone scan in everyone who is at high risk of osteopenia. Apoptosis and stomatitis is a sign of immune compromise and could be a sign of celiac disease, and nobody actually knows why people got mouth ulcer. A dental enamel defect can be the only manifestation of celiac disease. This, as you can see, celiac disease affecting many organs, and nail deformity also has been one. This is a very beautiful case that we have presented a few years ago. And you see that nail deformity and onycholysis on the left side and improving after gluten-free diet treatment. Thus, we were not able to diagnose celiac in obesity and overweight people 50 years ago. But by developing the celiac sensitive serological tests, we are able to do that. And a study we did in West Midlands a few years ago that showed over 44% of people had a BMI of 25 or over, and 13% of them actually were obese. Dermatitis epidermoides like erythematous macule, urticarial papules, tense vesicle with severe pruritus is another form of gluten-related disorder. And over 75% of these people have got intestinal abnormalities similar to celiac disease, and the treatment is gluten-free diet, of course, and Dapsone. There was a talk about fertility. These fertility organs are definitely also related to celiac disease. There's a study we performed a few years ago that showed about 60% of male and female infertile had a positive test. And interestingly, about 7% of all these people were AGA deficient. AGA deficiency is something like 1% in general population, 1 to 3%, but in celiac patients actually is much higher. The other organs affected is brain. Well, like, people can, there has been some association found with MS, epilepsy. Epilepsy usually can cause cranial calcification for some reason. We do not know why that happens. But also gluten ataxia, which is abnormal gait, balance, speech that characterize gluten ataxia. And you can find the position of the antibodies in cerebellum, pons, and medulla, and the small bowel. Of course, mental health is also important in celiac. In a meta-analysis we done a few years ago, we found that mood disorders and depression, anxiety were much more common in gluten-related disorders compared to general population. Just to summarize, actually, you see that gluten can affect any organs from brain, thyroid, pancreas, fertility organs, mental health, skin. The question is, what is really causing? What is the causal agents? This is a tipping a typo here. It should be causal, but it's an Italian version of that. This gluten actually is the main antigen, but there are other things like amylase trypsin inhibitors and fructans, which are also important parts in wheat and barley. Gluten proteins are gliadin and glutenin, with a proportion of 70 to 30%, and they look after the raising and elasticity of the bread. This gluten has the ability of inducing an immune reaction in susceptible individuals, those who have got a genetic predisposition for disease. But genetic predisposition is not the only factor, because 40% of general population have a positive DQ2 and DQ8 haplotype, but only 1% of these people develop celiac disease. Thus, there are other factors that influence the manifestation of disease, and that is environmental factor. We call it epigenetic, which is gluten exposure in large amount, infection, and pregnancy seems to be between the triggering factor. What happens really when you are exposed to gluten, or gluten is injected intradermic, that lead to the amidation of gluten peptides, and that stimulate the gluten-specific immunity, which is B cell and T cells, which finally stimulate the cytokine release, which is causing the intestinal and extraintestinal effect. And finally, what happens in a small bowel, you could see in the left side, there is various long and thin villi. By increasing the inflammatory cell, gradually go to the flat mucosa. I must say that there is no atrophic changes, but there is thickening of the mucosa because of inflammation, and the villi usually drown in the small bowel inflammation. And this is showing the remodeling of the small bowel mucosa. What happens exactly? The thin villi is going to change to a flat villi, and endoscopically you could see at A, very beautiful villi, and that changes to scalloping and fissuring in C, and finally mosaic pattern, which is a flat mucosa. So far we said gluten can affect any organs. That means actually that cause systemic inflammation. It is very unlikely that the inflammation is confined to 20 centimeters of a small bowel. That means actually gluten produced in systemic inflammation can cause damages in any organs, thus intestinal and extraintestinal symptoms. This is also why we do not see any correlation between the clinical manifestation and intestinal damages, the degree of intestinal damages. This milder enteropathy or milder intestinal damages, they are just the same like severe intestinal damages causing the symptoms and manifestation of issues. And in fact, this is a consensus study we did in 2015, and we showed actually inflammation and malabsorption start even before we see any kind of changes in the small bowel. Having said that, when we are talking about non-responsive celiac disease, most of the time, we see that there is a severe intestinal damages in these people. This interpretation of the histology should be in the context of clinical presentation. What I'm trying to say, histology in its own hasn't got much value. This should be an interpretation with the other parameter. What do we mean by non-responsive celiac disease? While actually the majority of people respond to a gluten-free diet, about 30% of people will continue to express symptoms despite adherence to gluten-free diet. That means some people have got a slow healing due to a various etiology. This non-responsive celiac disease is defined like persistent symptom and sign, laboratory changes, persistent histology, despite adherence to a gluten-free diet for 6 to 12 months. In UK, there is a center in Sheffield and in Cambridge. They look after rare disease, like rare disease collaborative network. And usually most of the people are referred to the center and they look into the etiology and find out what is really going on. And I must say that I am very pleased to say that we have succeeded to organize similar thing in New Zealand, in Palmerston North, and we are connected to the international network, France and UK, especially for difficult cases, because, for instance, refractory celiac disease can be really very difficult to manage and difficult to diagnose. Thus, we are able to discuss that in kind of international MDT and make a correct decision for those people. What are the causes of persistent symptoms? The most important and prevalent cause is really intentional or inadvertent gluten ingestion. The other cause are microscopic colitis, lactose intolerance, thyroid dysfunction, malignancy, small intestinal bacterial overgrowth, and refractory celiac disease at the end. Refractory celiac disease is defined by persistent malabsorption symptoms, flat duodenal mucosa despite a strict gluten-free diet for 6 months to 12 months. Thus, we have two forms of refractory celiac disease. Type 1, which is normal intraepithelial lymphocyte phenotype. There is no changes. And type 2 is abnormal intraepithelial lymphocyte. Really, this is the main difference between the two. It's a rare condition before the age of 50, but it can occur. Refractory celiac disease is a bad news, unfortunately, and can affect any gastrointestinal organ, again, by increased dose inflammatory cell, abnormal inflammatory cells. Type 1 is very benign, usually improves after treatment with a combination of aggressive nutritional support, adherence to gluten-free diet, under the guidance of a trained dietitian, and also alternative pharmacotherapy like steroid and immunomodulator like azathioprine. Type 2, unfortunately, is a bad news. Thus, that is, by contrast, clinical response to gluten-free diet is limited, and the prognosis is usually poor. There are severe complications like ulcerative jejunitis and enteropathy-associated T-cell lymphoma can occur. Fortunately, the prevalence of refractory celiac disease is rare. It's only 1 to 5% of celiac patients. But when you look at the prevalence of refractory celiac disease in referral center, that can increase to 10 to 18%. Unfortunately, affect a female 70% compared to 30% in male. This clinical manifestation is persistent diarrhea, steatorrhea, abdominal pain, unintentional weight loss, and multiple vitamin deficiencies, and also thromboembolic disease can occur because coexistent with other autoimmune disorders. The laboratory finding is the most important is low hemoglobin and also low albumin, which indicate a poor prognosis, unfortunately. Abnormal liver function tests can occur in people, but half of these people may have abnormal liver tests. Diarrhea is usually associated with significant steatorrhea, just a fatty stool. And celiac serology could be positive or negative. This one is celiac disease when is celiac serology when it's positive is mainly related to gluten contamination or coexistent with other autoimmune disorders. I would like to show you what the villi changes here. You see this beautiful villi, you can see it very nicely, and changes to totally a flat villi there with fissuring, and that's where we can see the immune-related damages in the small bowel. This diagnosis is based on clinical and pathologic findings. The main finding is really these people with refractory type 2 celiac disease are really very ill. You cannot miss that. And diagnostic-wise, the abnormal T lymphocyte is the key for those people. I'm going to illustrate two cases that were referred to Palmerston North from Hawke's Bay and Lower Hutt. A 50-year-old lady from Hawke's Bay was diagnosed with celiac disease since 2018 based on serology and positive histology and HLA positive. Celiac serology in this lady was positive all through the time until we saw her. The blood tests otherwise were normal. She had chronic constipation, anxiety, depression, mood disorder, chronic fatigue, joint pain, ache, a lot of symptoms. This saw a dietitian in Hawke's Bay and did not identify any trigger for gluten contamination. We also did a dietetic assessment in Palmerston North. We did not also find any reason to doubt that, but we did not exclude the gluten contamination. The histology in 2022 was very worrying and showed a severe abnormality with some evidence for possible refractory celiac disease. That was really very complex case. We have discussed that with the international colleagues. This is Christopher Sellier from Paris and David Sanders from UK. We discussed the case and we agreed to try a gluten contamination elimination diet and repeat the serology and gastroscopy in 8 weeks' time. Gluten contamination elimination diet is guided by a trained dietitian, no processed food, natural gluten-free, but that's going to be described by a dietitian later in details. After follow-up, in 8 weeks, we saw dramatic improvement of symptoms with amazing improvement of life quality. Pain and fatigue disappeared. She lost about 13 kg during the elimination diet. We repeat the gastroscopy that did not show any abnormality, and histology totally normalized. And further celiac serology also became negative. That was amazing. Even though we did not find a reason for gluten contamination, still after going through the gluten contamination elimination diet, that was very strict, and that was the only reason that we get everything negative again. It must have been inadvertent gluten contamination in this case. The other further dietetic assessment also showed that she had sensitivity to dairy, salicylate, artificial sweetness, and caffeine. The next case is a 49-year-old lady who was referred because of abnormal liver function test. She did not have much clinical symptoms, but we thought that abnormal liver tests might be related to celiac disease. But the other differential diagnosis was that she might have autoimmune hepatitis. She also had type 1 diabetes, which was diagnosed at age 5, complicated with diabetic nephropathy. Gastroscopy performed before we saw her showed milder abnormality with increased lymphocytes in the small bowel. This is the blood test. You could see that alkaline phosphatase, ALT, and AST were positive. And she was supposed to have a liver biopsy. We canceled the liver biopsy, and we put her on 8 weeks gluten contamination elimination diet. And this is the blood test you can see after 8 weeks, which is nearly everything normalized, actually. Her HbA1c also improved. I must say, she also had a positive serology, celiac serology, all through the time since she was diagnosed. That has normalized. And just the diagnosis again, inadvertent gluten contamination. In conclusion, gluten contamination stands high in differential diagnosis of less responsive patients. And persistently positive antibodies suggest gluten contamination. A detailed evaluation of strictness of gluten-free diet should really be guided by a skilled and trained dietitian, which is causing very much improved. Thank you very much.
Great, we've had a few questions come in. Feel free to keep sending them through. If we don't get to them all today, then we'll send something around after with some short answers. But we've got a question here that's about celiac disease affecting the body in a range of ways. Can undiagnosed celiac disease cause or trigger other autoimmune conditions?
That's a very good question. Yes, actually, there is a lot of association with celiac disease and other autoimmune disorders like Hashimoto thyroiditis, primary biliary cholangitis, and rheumatoid arthritis, and many, 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 many others. Yes.
We've also got a question here about following a strict gluten-free diet and whether that reduces the risk of infertility.
Yes, actually. I have a very beautiful case. Actually, we published that as well, not only in celiac disease, but also in non-celiac gluten sensitivity. We had a female 45-year-old who did not get pregnant. Her antibodies were all negative. A small bowel biopsy was negative, but she tried a gluten-free diet for 6 months, and she became pregnant. She was under fertility treatment for those things, but she got pregnant actually naturally and had 2 beautiful sons. Yes, definitely.
Also a question about whether there's any new research coming out about how to help people with the refractory celiac?
Well, definitely, yes, there is much better than 20 years ago. We have more possibility. There are, as I said, refractory type 1 is very easy to manage. We have just refractory type 2, which is very difficult to treat. And fortunately, that is very rare. I think type 2 is less than 1%, but definitely the treatment is like any other malignancy with chemotherapy and hemato-oncologist input, yes, much better.
We've got a question about how can someone be referred to the clinic in Palmerston North with non-responsive celiac?
Just via GP, really. If you ask your GP or gastroenterologist you are seeing, they usually, the referral come to there were mainly by gastroenterologists, but I think your GP and gastroenterologist both can do that.
Great. Also a question about developing non-responsive celiac after following a gluten-free diet for a number of years.
It happens. Actually, some of the people with refractory celiac disease might be initially responsive, but then become unresponsive for some reason. There is environmental factor which we are not aware of why actually do that.
We've got a question about contamination of food supply, and there was an earlier question as well about pesticide residue being a concern as well. So how can people remove risk from the supply chain?
That's a good question. I think we have a talk this afternoon, dietitian, my wife actually, is going to talk about that. She's going to address that issue for you.
Another question about if someone has the gene for celiac disease, how likely is it that this will develop into celiac disease, and can it be avoided?
Yes and no. As I said, over 40% of general population have got a positive genetic background, and only 1% of them actually develop celiac disease. There's a gastroenteritis, pregnancy, unfortunately, for some reason. And gluten exposure, a lot of gluten in diet seems to be actually a triggering factor for that. But I think actually a healthy diet, less processed food, more fiber would be protective in any autoimmune disorders, including celiac disease.
We've got a question about whether you can have low antibodies but high inflammation markers in blood tests.
Low antibody for high?
With high inflammation markers?
Yes, I think if the antibody is very high, that signifies an important intestinal lesion. That's why in pediatric medicine, we do not actually do further biopsy if they have a very high titer of TTG 10 times more than normal, and if they have a positive endomysial antibody after that, which I think the pediatricians know that better than I do. But this is definitely, there is a correlation between serology and histology, definitely. Yeah.
Another question about a child developing symptoms shortly after introducing gluten with a celiac mother. The child is on a gluten-free diet currently. Is a biopsy necessary in this case?
Well, if they have positive serology and fulfill the criteria, is more than 10 times above normal value, then they do not need a biopsy. That's what the guidelines say.
And kind of following on from that as well, if there's a celiac mother with children, how often should the children be retested for celiac?
Usually, we know that about any first-degree relatives has got 10 to 15% chance of developing celiac disease if you have a sibling or a mother or a father with celiac disease. So I think every 2-3 years, and also if they have any symptoms, it would be worthwhile to check celiac disease.
Just one last question. Question about whether someone trying for, or woman in fertile periods, whether they should be taking folic acid daily in case they fall pregnant.
That's a very good question for dietitian as well. I think yes. The short answer is yes, but I will let someone who knows better than I do to answer that question.
Cool. I think that's everything from Q&A, and we'll respond to any others.
Thank you very much.
Thank you very much, Cameron.